So, low back pain. I see a lot of low back pain. That's essentially the vast majority of my clinical work as an osteopath. And I guess sometimes it's helpful for patients to have an idea as to what it is that's running through my mind when I'm taking a case history. And some of the non-mechanical causes of lower back pain, so as to ensure an element of safety and ensure that the patient have not missed anything, any causes of pain, lower back pain, that are non-musculoskeletal in origin. So with all patients with lower back pain, the usual things with MSK is your dehydration of a disc, some level of wear and tear on the discs, plus or minus the vertebral bodies, what we call spondylosis. This is referring to the lower spine, lower back. So this is all in the context of lower back. And these are kind of the general first few things. And there are some specific issues where you've got facets, the facet joints, so you could have dysfunction in around those, irritation to the area in that region. And if the pain is, rather than the center in the bottom, it could be more to one side than the other, so what we call paracentral or parasagittal, and that essentially points more often than not to situations such as the sacroiliac joint itself, hence SIJ dysfunction. Okay, all that's easy said, done, fine. But what happens when I'm actually taking the history? So I'm identifying the site. Is it in the center or is it more to one side than the other? Is it paracentral or central? That'll give me an indication as to what anatomical region I'm looking for. Is the pain constant or does it come on and off? Are there any aggravating factors, any factors that actually exacerbate the symptoms that might give me an indication mechanically what's going on and therefore point to certain structures? Is the pain intermittent or is constant, or is there any position of ease or is there not any position of ease? And in the absence of a position of ease and the fact that the pain is constant, then I start to wonder, I start to think about things a little bit outside the MSK system, outside the rims of osteopathy in many degrees, and consider some of the nasty stuff like myeloma, cancers, that kind of thing. Okay, so then we move on to what we call radiculopathy, pains, symptoms rather, down the lower extremities, i.e. the legs, the buttocks, the thigh, the calf, and depending on where exactly the pain is, the symptoms rather, these pins and needles, numbness, weakness, or filling sensations, what we classify otherwise as together radiculopathies, where exactly those symptoms are, and again they will help me to differentiate and delineate whether they come from the buttock, i.e. piriformis syndrome, or are they coming from further up in the spine as it exits, as the nerves exit the spine, the apertures through which the nerve pass out. And so that's what we're looking there for. Again, in a situation here, I'm also asking the patient whether the symptoms in the leg are exacerbated by bearing down, coughing or sneezing, what we call Valsalva maneuver. And were that to be the case, then we've got to contextualize the possibility of involvement of any disc bulges, disc injuries, because what happens when you cough, sneeze or bear down, you increase the intra-abdominal pressure, and that in turn causes further impingement on the nerves. That might be trapped the spinal nerves themselves, again as they exit what we call the ivia, the aperture through which the nerve exits, the spinal column. Okay, so moving on to the non-mechanical causes here now. One of the biggest things your general practitioner and any competent practitioner in the field of MSK absolutely must screen for this. Absolutely must. And it's called Cauda Equina Syndrome. Cauda Equina Syndrome, it's essentially, according to literature, is what we call a medical emergency. Okay. Now, Cauda Equina Syndrome, your spinal cord, your spinal column, all the way from the top of your neck down to your bottom. The spinal cord, however, doesn't run all the way down. Okay, it does not run all the way down. It actually stops and it starts to tail off at the T10 level, and by the L1 level, it actually generally finishes. The spinal cord is no longer the spinal cord. Instead, it becomes what we call the Cauda Equina. So imagine your biro pen, and the bottom, the pointy bit at the bottom, that bit is what we refer to as the conus medullaris, and that runs from T10 to L1. So it kind of starts to point down, so there's uniform down and then it starts to point off. That conus medullaris, T10 to L1. And so in that conus medullaris bit, what you get is you get a whole array of nerves going off, and that is what called the Cauda Equina. Cauda means tail, equine refers to horse, i.e. horse's tail. Ladies who tie their hair in a ponytail, same concept, Cauda Equina, so horse's tail. Cauda Equina Syndrome is a situation where you've got compression of the Cauda Equina. The nerves that form part of the Cauda Equina involve those nerves that innervate your anal sphincter, your back passage, and those nerves that innervate your bladder, the actual muscle to the bladder. So the bladder is no more than a vessel. It's a muscular vessel. The muscle itself is called the detrusor, and so the nerve that innervates that as well, and as well as some of the sensory nerves in and around the saddle region of your bottom. The saddle region essentially is that region in your bottom which would be covered if you were to sit on the saddle on a horse. Okay, if you were to straddle a horse on the saddle, that area is what's called the saddle. So in the context of Cauda Equina Syndrome, I have done a video separate on this, very clearly specifying a thorough, detailed understanding. So we look for bowel and bladder dysfunction, and we look for saddle anesthesia. I'm not going to go further on that. You can refer to the video there. It's outside the range of this particular video. It'll lose focus. So that's Cauda Equina Syndrome. We would absolutely check for. If the patient is, let's say, 55 male, 55-year-old sedentary lifestyle, quite a large fella, the pain is constant, it's dull, it's aching, it's been there for a long time, it's not getting better, there are no position of ease, then you're looking at, aside from the nasty that I spoke of, yeah, okay, we've considered all the arthritis spondylosis, but in this particular context, if there's an element of heart issues as well, we've got to remember the possibility of a AAA, an abdominal aortic aneurysm. Okay, because the aorta at the bottom sits against the vertebral bodies of L2, 3, 4, and therefore you look at these vertebral bodies on cadavers and they've got some level of indentation in the vertebral body. In the context of an aneurysm, which is a ballooning of the blood vessel, the aorta is the biggest blood vessel in the body, and the weakening in that essentially causes an aneurysm, and that could be actually causing the symptoms. If this patient now, let's say, is 60 years of age or plus, now in practice, I usually, again, take the mark of 50 because there's evidence to suggest the same. I will always also screen for their prostate. Okay, it's less likely in the 40s, 50s, 60s, more so 70s, almost certain. The prostate gland, again, I've done a specific video on this, so I'm not going to elaborate too much, but the prostate gland, if that's enlarged, won't give you a problem in the lower back, but if it's cancerous and there are metastases, so this cancer has metastasized to the back, the spinal column itself, then you've got room for concern. So you always want to make sure there's no possibility of prostate, you do screen for the prostate. If this patient now, let's say, is kind of in their 70s, then again the myeloma comes in, so your CML, so leukemias, my apologies, so chronic leukemias and the likes of these CML and CLL. Okay, so now let's go on to the females. So what could I consider in females? So with females, what we're looking at doing, so let's say it's a young female, childbearing age, and you've got to absolutely consider with females that the key is that you make sure you screen for the obs and gynae, a good gynecological history, and make sure that is there a possibility that the pain is cyclical, and therefore could it be an element of endometriosis? Is the pain there in the context of childbearing age, that this lady could possibly be pregnant? And I have seen a patient who came in and completely unaware, of course, and these things do happen. And further history revealed, so the nature of the symptoms was come on without any cause, no mechanical associated history, and it was non-specific, diffuse. It was an aching sensation that had progressed over the last few weeks, and so you kind of think, you're wondering, but then she was only 20 odd, I won't give too much, so mid to late 20s, and so you're thinking, okay, you couldn't really be cancer here, it couldn't be any of the nasty stuff, so you check for the genitourinary tract, and you ask to make sure is there any possible infection down below, so discharge, smell, odour, and any spotting, etc. And then we moved on to identify that she had missed a period and that she was having unprotected sex. So, again, these things can happen, and of course, the first thing we requested here was to do a urine pregnancy test. And of course, again, was there much I could do here? The best osteopathy here for me was to say, off you go and get yourself assessed. No treatment provided. So there's those kind of things. Young females, endometriosis, make sure there's no genitourinary symptoms. It could be a UTI, urinary tract infection. And again, you're looking for signs of lower urinary tract symptoms. And again, I'm not going to elaborate too much about polyuria, urgency, burning sensation, excessive odor, etc., etc. And you go on, and you're then looking at patients again as a female that is a PID, pelvic inflammatory. So a lot of the gynecological issues that you need to be aware of and make sure you're not possibly is there any cause of that. The last thing I want to throw in here, the light of an ovarian cyst. So again, one of my patients came in and the pain was very much in the right iliac fossa, right at the bottom over here in the lower back. So bloating therefore was, abdominal symptom you must also check for, making sure there's no bloating, making sure there's no abdominal pain, cramps, those kind of things. So these are just some of the things that I'm thinking when the patient presents to me with lower back pain. The other thing is kidneys. So kidneys again in the flank, so your lower back. The kidneys are what we call the retroperitoneal organs. They actually sit in the posterior compartment, in the compartment at the back inside your abdominal cavity. And so if there is any inflammation to these kidneys for whatever reason, it's not necessarily infection of the kidneys, the actual is what we call pyelonephritis. That usually is a complication of untreated urinary tract infections that has ascended, or so it ascends upwards, and then you've got a nasty piece of work. And there are very pathognomonic symptoms of that, such as chills and rigors, flank pain, and nausea and vomiting, and it's quite a nasty piece of work. So you've got that kind of thing there, but simple inflammation of the kidney, and that can also in its entirety give you symptoms. And again, here we're looking at when we're assessing the area, have we got issues where the pain is constant, it's no movement relieves it, is it a nauseating pain, and so on and so forth. So there you have it. When you come and see me, or otherwise when somebody takes a case history in the context of lower back pain, and there are numerous other causes. Please, I'm just giving you a complete and a very basic whistle stop tour here, just to give you an indication as to some of the non-mechanical causes, the non-musculoskeletal causes of lower back pain that immediately I'm thinking of when a patient presents and what I'm screening for. I hope that helps, and I hope you enjoy the video. Thank you very much.